Thank you for the introduction. I would like to present my 15-month progress on tissue acquisition in solid pancreatic masses. So as mentioned already, my name is Engh, and my vision is to improve the diagnostics of pancreatic cancer to lead to better outcomes for patients by contributing to clearer guidelines for more efficient diagnostics of pancreatic cancer. I have two projects on this topic. The first one is a comparison of diagnostic adequacy of different needle tips for this tissue acquisition. This is a network meta-analysis. And for the background, endoscopic ultrasound-guided tissue acquisition is the recommended method of biopsying solid pancreatic masses. However, 10% of samples are usually inadequate for analysis. This leads to a need for resampling, which carries a risk of adverse effects. Sedation need costs of about $2,000 per patient, and we think we can avoid this. There are 5 available needle types. One of them is an FNA needle, the Engh type. And then there are 4 different FNB needles, the reverse bevel and forward bevel Westcott, the Francine, and the fork tip. Currently in the guidelines, it only says that you should use a 19-gauge FNA or FNB needle or a 22-gauge FNB needle to acquire a core tissue specimen. However, the level of evidence is low and the recommendation is weak. So our aim was to compare the diagnostic yield of all the needles used for tissue acquisition. For this, we have a PICO of patients undergoing endoscopic ultrasound-guided tissue acquisition for a solid pancreatic mass. The intervention and comparator is any FNA or FNB needle, and our outcomes are diagnostic adequacy, specimen yield, number of passes, adverse events, and technical failures. We started off with around 3,600 search results. We also updated the search in May of this year, and we finally had around 60 eligible articles. From this, we were able to set up this network for histological adequacy. The size of the nodes here represents how many patients were included, and the thickness of the lines, how many studies we had for this comparison. And from this, we created this ranking of needles, where the best needles were the fork tip needles and the Francine needles, and the worst by far were the Engh, which of course, since these are not histology needles, it makes sense. We also set up a network disregarding the size of needles because our hypothesis was that this was a secondary impacting factor, and found the same where fork tip and Francine needles were the best and reverse bevel and Engh the worst. For cytological adequacy, the network works the same way. We were able to compare all the main needles in at least one size, and we found again that the fork tip needle was the best and Engh the worst. Also here, disregarding the size, we were able to establish a ranking of needles. For the outcome of technical failures, we found that these were actually very rare events, so the comparison here is weak, but we also managed to set up a ranking where Francine needles performed the best, and unfortunately reverse bevel, which otherwise performed quite well, the worst. Also disregarding size, we were able to set up a ranking which shows about the same results. Adverse events had the same limiting factor as technical failures of a very low event rate. And here, the reverse bevel was actually the best, and the Francine needle, one of the newer ones, the worst. But you can see from the color scheme here, actually, that the ranking showed all of them in around the same range. In summary, this was a network meta-analysis including more than 50 studies and thousands of patients, and we were able to compare all the available needles for endoscopic ultrasound-guided tissue acquisition of solid pancreatic lesions. However, as limitations, there were high uncertainty leading to wide credible intervals, and there were no statistically significant differences in the pairwise comparisons. However, we would like to conclude that fork tip and Francine needles are best for achieving adequate samples, and Westcott needles carry the least risks of adverse events, but these are rare either way. So we think that you should choose fork tip or Francine needles if adverse effects and technical failures are not of concern, and these are rare, like I said, so we consider them to not be of the highest concern. And we suggest 22-gauge or 25-gauge fork tips as the best to achieve a tissue core. For research, we would like to suggest that further RCTs comparing several needles should be performed, and adverse effects should always be clearly defined in the future papers. Furthermore, adequacy for cytology and tissue core for histology should be separately reported. Currently, this manuscript is still in the writing phase because I want to set up one further network which actually compares the sizes. So we're still working on the data for this one. Our target journal will finally be gastroenterology. My second meta-analysis is about contrast-enhanced endoscopic ultrasound And as a background for this, we have the same sampling method. However, for the ultrasound itself, there are different methods. And if you use a contrast-enhanced endoscopic ultrasound, you may increase the visibility of the lesion. However, you would reduce the time window you have to get the sample. So our aim is to investigate whether contrast-enhanced endoscopic ultrasound may increase the sampling adequacy of pancreatic solid masses, and we actually think this might go either way. Our population was the same. Our intervention was contrast-enhanced endoscopic ultrasound and the comparator conventional endoscopic ultrasound. We were further looking at the same outcomes of diagnostic adequacy, specimen yield, number of passes, and adverse events. Here we had only 343 search results, and we ended up with 11 eligible full texts. And without further ado, our results show that the diagnostic adequacy does not differ. However, our level of evidence was very low due to the very serious imprecision. This stemmed from the Sugimoto paper, which you can see is actually significantly in favor of contrast-enhanced endoscopic ultrasound. However, if you look at the conventional endoscopic ultrasound, you find that the event rate for successful sampling in the conventional side was incredibly low at only 25%. Which was strange to us, so we had a closer look, and the first pass in this paper was actually performed by inexperienced endosonographers. We then set up two further analyses, one taking the second pass from that paper into account, which was performed by expert endosonographers, and one taking that study entirely out. Both of these suddenly increased to a level of evidence of moderate, showing that there's absolutely no difference between the interventions. For our secondary outcomes, which were very low and not poolable, we also found 0 event rates for technical failures and adverse events, and equal in both arms. We also found 3 ongoing RCTs, so hopefully this will be updated. But based on this comparison, and based on what we found from Sugimoto, we think that there's likely no difference in diagnostic adequacy, but we think that contrast-enhanced endoscopic ultrasound may aid inexperienced endosonographers get an adequate sample. The strengths of the study are that we only included randomized controlled trials, and there was low risk of bias for the main outcome. However, we had few included studies and differing methods and differing definitions across papers. We also had low number of events for the secondary outcomes and a low or very low level of evidence for the secondary outcomes. As an implication for practice, we think that this may be worth using only if only inexperienced endosonographers are available, and we think that any further RCTs should stratify for endosonographer experience. Current ongoing RCTs should report the experience and the lesion size, and this meta-analysis may need updating once the ongoing trials are published. This manuscript was submitted as of today, finally, and hopefully, good news for Christmas, who knows. My first paper hopefully will be submitted over January if I have some time over Christmas to finally complete that. So I would like to thank you for your attention with this quote, an ancient proverb from Germany. A good paper tells a story. A published paper cites reviewer 1, survives a reviewer 2, and buys reviewer 3 a beer at the next conference, or at the CTM, a bottle of wine. Thank you.
Excellent presentation. Thank you very much. You have mentioned that there are little adverse events. However, there are some. Which ones are they?
Well, you can have pancreatitis actually caused by the sampling, for example. Yeah, we know that one. There's bleeding, self-limited bleeding. There have been few reports of tumor seeding, but it hasn't been actually shown to be significantly increased in the case of the sampling. These are the main ones.
I have a question as well, Marie, about your first project. We are now talking about personalized medicine in oncology. This is really a hot topic. Is there any data in these articles, because your search is pretty recent, is there any data in the articles regarding the quality of the sample in terms of performing these newer techniques, genetic testing, molecular analysis? Which of the needles is better for acquiring sufficiently good data for this kind of analysis, downstream analysis?
Thank you for this question. There are some randomized trials that are specifically going into the nucleic acid content of the sampling. I haven't found enough data to truly pool this, but I'm planning to actually add it to the discussion part because this is such a hot topic right now and it's very important.